So we're going to talk about the LIDCO machine, the cardiac output studies machine, if you like, that often sits by the patient and gives us various bits of information. It is useful in some circumstances, not in others, but really the aim of this lecture is just to give you some idea of what some of those values mean, how they affect the patient, and what we can do to change those values. So let's just quickly run through a very quick revision of what's going on in the heart. So obviously you've got the four chambers here. So we've got the right atrium, the left atrium, not the left atrium. We've got the right ventricle, the left atrium, and the left ventricle. Blood enters the heart on the right side, so it comes in from below and above, and below is the inferior vena cava and above is the superior vena cava. Once it's gone into the heart, it's then going from the right atrium down to the right ventricle, out of the heart via the pulmonary artery and into the lungs. Then it's being oxygenated in the lungs, coming back into the left atrium via the pulmonary veins, down into the left ventricle, and then up and out of the heart via the aorta. So if we're going to talk about the cardiac output studies, we need to understand what cardiac output actually is. So if we start with a formula, so cardiac output equals heart rate times stroke volume, and then blood pressure equals cardiac output times systemic vascular resistance. But let's start with stroke volume. What is stroke volume? So stroke volume is basically the amount of blood that is ejected from the heart every time it beats. So the standard number for stroke volume is between 60 to 90 mils per beat. Okay, so how much blood is ejected after it beats? Heart rate obviously is how fast the heart is beating, so heart rate times stroke volume will give us our cardiac output. So cardiac output is the amount of blood ejected every minute. So let's put some numbers on this. So let's assume, just to make the maths quite easy, that the heart rate is 70 beats per minute. And let's assume, again to make the maths easy, that the cardiac output is 70 mils. Now if you do your maths, that's 4,900 mils per minute, or approximately 5 litres. So standard cardiac output is 5. So when we're talking about cardiac output, there is a number of factors involved. There's 3 parts to your cardiac output. There is your preload, contractility, and afterload. So what is preload? Preload is essentially how filled the chamber is, be it the atria or the ventricles, with fluid before it contracts. So if it's this full, then remember that the heart is basically a big elastic bag of tissue, of muscle, okay? And the more you fill it, the more it will stretch. So if you fill it more and more and more, you get more and more stretch. And like a good elastic band, the more you stretch it, the more it will recoil. So if you get an elastic band and stretch it and stretch it and stretch it, it will fly across the room. If you don't stretch it so much, it won't go so far. So if you give more fluid into the ventricles, then that stretch is going to be even bigger, up to a point. Obviously the heart can only stretch so far, but that essentially is what preload is. So how can we affect preload? We can basically give fluid. So when the patient's dry, for example, if we give fluid, then we are going to increase that preload, increase the stretch of the heart muscles, and hopefully increasing that stretch will increase the recoil in the heart, improving the cardiac output. So what about contractility? Well, remember when I talked about preload, I said that the heart is a stretchy muscle. A good healthy heart has got good contractility. However, if, for example, I give the patient a myocardial infarction and some of this heart muscle has died, then the contractility is going to worsen. The heart won't be able to bounce back as well as it could have done because some of that muscle has actually died. Or if the patient has got a big baggy heart anyway because they're old or they've got a cardiomyopathy, then again the contractility is reduced. So how can we increase contractility? Well, there's a number of drugs we give, and one of the common ones that we give is adrenaline. Adrenaline will increase that contractility. It will also increase the heart rate a little. So remember, its cardiac output is heart rate times stroke volume. So we've increased the contractility, potentially we increase the heart rate a little bit. By increasing the contractility, we've also increased the stroke volume because the heart is now contracting better than it was. And then the other part of the equation is the afterload. So the afterload is the pressure that the heart is pumping against when the blood goes out of the aorta. So if you can imagine that your blood vessels are nice, big, wide blood vessels with a certain amount of fluid in, that fluid will exert pressure against the walls of the arteries and the veins. But now if I make that artery much smaller with the same amount of blood in it, that pressure is now going to be much greater. Okay, volume and pressure are related. So if you increase the volume inside the vessel, not increase the volume, if you decrease the diameter of the vessel and keep the same volume in it, then you're going to increase the pressure against the walls. And this essentially is what afterload is. So if you increase the pressure against the wall, what you're essentially doing is increasing the blood pressure. So how do we do this in ITU? Well, this is via one of the most common drugs that we use, noradrenaline. So noradrenaline is a vasopressor. It does increase contractility a little, it does increase the heart rate a little, but not as much as adrenaline. Its main action is as a vasopressor. So it makes all those arteries go from this down to this. And remember, I said that that will increase the blood pressure. And what you're effectively doing is increasing afterload. So to go back over it again, we had preload. We can give fluids. We had contractility. We can give adrenaline. And we had afterload, where we can give noradrenaline. So So we said earlier our cardiac output is 5-ish, there or thereabouts. However, remember on the LIDCO that we have a number called the cardiac index. Well, the cardiac index is just related to your particular patient based on their height and therefore their weight and therefore their ideal body weight. So your cardiac index is more specific to your patient, and for those values you're looking at 2.5 to 3.5. Remember also that we talked about blood pressure equals cardiac output times systemic vascular resistance. So your systemic vascular resistance, like I talked with the afterload, can change if the patient becomes vasoconstricted or vasodilated. The resistance will go up or down. And again, your SVR is about 1,000, but if we index it, remember, to your specific patient's height, weight, etc., then the value we're looking for is more like 2,000. And then finally, the last number you will see, which is normally down in the bottom right hand corner, is something called the SVV, which is stroke volume variation. And this is telling us how dry or well filled the patient is, and it's expressed as a percentage. So just to try and help you understand this, that the heart is basically enclosed in the thoracic cavity, okay? And what happens when you breathe in is that the pressure, let's just undo that, silly little lines, is that the pressure drops when you breathe in the thoracic cavity, which draws air into your lungs, okay? But the heart being in there as well, every time you breathe in, the pressure also drops slightly in the heart, which effectively means that as you breathe in, a little bit more blood is sucked in to the heart as well. So that is called stroke volume variation. How much more blood is going into the heart when we breathe in, okay? Now, there will be a big variation if the patient's circulating volume is low, okay? It will make a big difference because there's lots of room in the patient's circulation. The difference between the stroke volume when you're breathing in and when you're not breathing in will be quite significant. But if the patient's well filled, that difference will be less. When you breathe in, the change in stroke volume will not be so noticeable. So this is the stroke volume variation, and it's normally represented as a percentage. And what you're aiming to do is to try and keep that below 10%. If it's greater than 10%, then the patient might need more fluid to bring that number down. However, there's a caveat to this. This really only works properly if the patient is sedated, ventilated, and not taking spontaneous breaths. If they're taking spontaneous breaths, the volume are going to be different from what the ventilator's doing, so it makes this number here not so reliable. So if the patient is not sedated, not ventilated, not taking or taking spontaneous breaths, then that number isn't so reliable. Okay? So we've got cardiac output, or cardiac index, 2.5 to 3.5, systemic vascular resistance or systemic vascular resistance indexed, approximately 2000. And then you've got your stroke volume variation, which should be less than 10%. Okay, I hope that helps.